Dear colleagues, this lecture is about the ECG findings in athletes and how to differentiate between normal and pathological changes. These are the guidelines or the European guidelines. The international ECG criteria divide the abnormalities into normal ECG findings, borderline findings, and abnormal findings. We will mention it in detail. Normal ECG findings: increased QRS voltage for left ventricular hypertrophy, incomplete right bundle block, early repolarization with ST segment elevation, ST elevation followed by T wave inversion in V1 to V4 in black athletes, T wave inversion from V1 to V3 only in young athletes below 16 years, sinus bradycardia or arrhythmia, ectopic atrial or junctional arrhythmia, first degree block, second degree Mobitz type 1 block. The borderline ECG abnormalities: left axis deviation, left atrial enlargement more than 42 millimeter, right axis deviation, right atrial enlargement, complete right bundle branch block. Abnormal ECG findings: T wave inversion, ST depression, pathologic Q waves, complete left bundle, QRS more than 140 millisecond, epsilon wave, ventricular pre-excitation, Wolff-Parkinson, prolonged QT interval, Brugada type 1, profound sinus bradycardia below 30 beat per minute, prolonged PR interval more than 400 millisecond, Mobitz type 2, second degree block, or of course complete AV block, premature ventricular contractions more than 12 per minute, atrial tachyarrhythmias, ventricular arrhythmias. Studies revealed that all athletes may get enlargement in left ventricular internal diameter, but the septal and posterior wall thickness may be increased or not. The common abnormalities: interpretation of inferior T wave abnormality occurs in 23%, right axis in 14%, intraventricular conduction delay 14%, means RSR dash, incomplete right bundle 10%, sinus bradycardia 10%, early repolarization 6%, and so on. This is the incidence of the abnormalities that can be considered normal. International consensus standards for ECG interpretation in athletes. Definition: T wave inversion means inversion more than 1 millimeter in 2 or more contiguous leads. Anterior V2 to V4 excluding black athletes and the young. Lateral in lead 1 AVL, V5 and V6. Inferior lateral 2 and AVF and V5, V6 and V lead 1 and AVL. Inferior 2 and AVF. Pathologic Q waves more than 0.25 millimeter or more than 40 millisecond or more than 1/3 of its R. Complete left bundle block more than 120 millisecond. Profound non-specific intraventricular conduction delay means QRS duration more than 140 millisecond. Ventricular pre-excitation, short BR less than 120 millisecond, and delta wave. Prolonged QT more than 470 millisecond in male and 480 millisecond in female. This is the definition of the abnormalities. Brugada definition: coved pattern, initial ST segment elevation 2 millimeter or higher with downward slope of the ST segment and followed by T wave inversion. Profound sinus bradycardia less than 30 beat per minute. Profound AV block, PR more than 400 millisecond. Mobitz type 2, intermittent non-conducted P waves with fixed PR. Third degree block, of course, is complete heart block. Atrial tachyarrhythmias as supraventricular tachycardia, atrial fibrillation or atrial flutter. PVCs more than 12 per minute. Ventricular arrhythmias, couplets, triplets, non-sustained VTAC. Borderline ECG findings in athletes. Some findings you can say abnormal but not pathological. The ECG findings may be increased QRS voltage, incomplete right bundle, early repolarization, the rise of the J point with ST segment elevation, Black athletes especially have early repolarization and T wave inversion from V1 to 3 and 4. Juvenile pattern below 16 years accepted T wave inversion from V1 to V3. Sinus bradycardia more than 30, this can be normal. Sinus arrhythmia is normal, accepted as in not pathological. Ectopic atrial rhythm accepted. Junctional escape. The QRS rate is faster than the resting P wave. First degree block accepted within abnormal but not pathological. Mobitz type 1 abnormal but not pathological. But in T-wave inversion can occur in hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia, and myocarditis. T-wave inversion in inferior leads also occurs in these items. ST segment depression in HOCM with dilated cardiomyopathy or myocarditis. Pathologic T waves in HOCM and dilated cardiomyopathy. So in summary, ECG interpretation in athletes has evolved to help distinguish physiologic findings from pathologic findings. Some form of T-wave abnormality, inferior, anterior, or lateral, accounts for 35% of ECG changes, were not normal but not pathological. This expression is important. When I write a report on ECG, I say not normal, or there are abnormal findings but not pathological. Other common themes include application of the international criteria for duration of QRS more than 140 milliseconds, or severe bradycardia or right axis. Among individuals with low to moderate cardiovascular disease risk, participation is allowed class 2A. Cardiac screening with family history, symptoms, physical examination, and the 12 lead resting ECG should be considered for competitive athletes. Class 2A, to screen the person, to ask him about his family history and to examine. Clinical evaluation, including maximal exercise testing, should be considered for prognostic purpose in sedentary people and individuals with high or very high cardiovascular risk who intended to engage in intensive exercise program. This is class 2A. So we can allow exercise if the history is negative for sudden death and the ECG is not pathological. For mitral valve prolapse, there are T-wave inversion in inferior leads with long QT and scar seen by magnetic resonance. These are the risk markers of sudden death in mitral valve prolapse. Exercise recommendation in individuals with cardiomyopathies, myocarditis, and pericarditis. Of course, it is dangerous to allow them to participate in exercise. The resting 12 ECG has limited value. Ambulatory ECG and preferably 48-hour Holter is important for detecting ventricular and supraventricular arrhythmia. Asymptomatic non-sustained ventricular tachycardia is having a considerable risk for sudden cardiac death in young individuals. Paroxysmal supraventricular arrhythmia may pose significant implications for the capacity, and atrial fibrillation, of course, is dangerous. Recommendations for exercise and sports participation in individuals with hypertrophic cardiomyopathy. Can you allow patients with HOCM to play exercise only if recreational exercise but not competitive exercise? This is class 2B. And participation in low or moderate intensity recreational exercise desired may be considered in individuals who have any markers of risk following expert assessment. If the patient is having any marker of risk, is not allowed to play. Don't forget that there are causes of sudden death in athletes due to congenital anomalous coronary artery. Now we see this example, the raised ST with bifid QRS in V1 incomplete right bundle. This is early repolarization. This is acceptable in athletes. Abnormal but not pathological. Here also early repolarization, raised ST, we raised J point, the junction between QRS and ST, and not only in lead 1, lead 2, but also in V4, 5, 6. This is early repolarization. This is abnormal, but not pathological if there is no family history of sudden death and or the patient does not get syncope. Here there is severe example of inversion of T wave in chest leads and lead 2 and AVF. This is hypertrophic obstructive cardiomyopathy. You cannot allow this to participate in competitive sports. Here there is prolonged QT, typical prolonged QT. Of course, this is not allowed to participate in competitive sports. Here, a comparison between two examples of T changes. Here, just flat or low T. This can pass as abnormal but not pathological. But here, T wave inversion with some ST elevation, this is abnormal, but pathological or not pathological according to the presence of other findings as family history or presence of syncope. Again, this is example in a black athlete, T wave inversion in V1, V2, V3 with ST elevation. This only in black athletes can pass as acceptable, not pathological. Again, here T wave inversion in inferior leads, you can pass it as abnormal but not pathological. But here, T wave inversion lead 2, 3, and the AVF, this is abnormal. And also, you can say pathological if the patient is having a history of syncope, chest pain, family history. The ECG criteria sets have been extensively described. There are 3 classifications: European classification, Seattle classification, and international classification. All 3 ECG criteria set classify ECG abnormalities as the presence of MOBITS 2 or complete AV block, atrial or ventricular tachyarrhythmia, left bundle block, prolonged QT, T wave inversion, ventricular pre-excitation, Brugada 1 or 2. All these are pathological. These are the 3 international classifications. European Society of Cardiology criteria, Seattle criteria, international criteria. The high-risk cardiac conditions include inherited cardiovascular conditions as HOCM, arrhythmogenic cardiomyopathy, dilated cardiomyopathy, prolonged QT, congenital cardiovascular conditions as coronary anomalies, bicuspid aortic valve, mitral ventricular pre-excitation, and mitral valve prolapse, cardiac valve conditions as mitral valve prolapse, aortic valve stenosis, moderate or severe, other cardiovascular conditions, aortic disease, Marfan syndrome, atherosclerotic coronary artery disease. All these are high-risk cardiac conditions. This slide is important. It shows the difference between the 3 guidelines: European Society, Seattle criteria, international. The most lenient permissible is the international. So in the European Society are very tight. They found abnormal ECG in athletes in 11.9%, but international, they permit some abnormality and only considered it abnormal in 5% of athletes. The borderline or uninterpretable ECG findings, ST depression less than 0.15 millivolt, not typically ascending or down sloping ST, pre-existing left bundle block, and ventricular pacing. These are differences published about ECG criteria. Results of the previous reference, they studied 2,500 master athletes. They concluded that ECG criteria recommended for use in athletes can be applied to master athletes ECGs to detect high-risk cardiac condition. The European Society criteria had the highest sensitivity for detecting high-risk cardiac conditions among master athletes. So the criteria for the young athletes applies also to master athletes. This is example of high raised ST segment with raised J point in lead 2, 3, and V5, V6. This is early repolarization. This can pass as abnormal but not pathological, and he can participate in exercise. Here, inverted T with raised ST in V1, V2, V3, and even V4, this only in black athletes can pass as acceptable, not pathological. Otherwise, it needs more investigation. Here, inverted T in V2, V3, and V1 in young athlete, 12 years, this is completely acceptable as within normal. Here, there is T inversion in V1, V2, V3 with some J point elevation. This is early repolarization. In black athlete, this is accepted as not pathological. Here there is T inversion with ST elevation, have some similarity to Brugada type 2. In a young person, 16 years, this can pass as not pathological. Here, two examples. Here, flat T all over and inverted T all over. This is arrhythmogenic right ventricular cardiomyopathy. You cannot allow this to play competitive sports. Here, T inversion in V4, 5, 6 and lead 2, lead 3 ABF. This is hypertrophic cardiomyopathy. This is classic Brugada syndrome, raised ST with downward sloping and followed by T wave inversion. Brugada classic type 1. Of course, this is not allowed to play competitive sports. Brugada at one time divided the classification into type 1, 2, 3, here with markedly elevated ST with downward slope and inverted T. Here, 2 millimeter only elevation of ST, and here saddle shaped ST. But after this, Brugada himself said no, all these are Brugada, but just fully manifest and not fully manifest. But still some professors follow this classification, type 1, type 2, type 3. Here is example of raised ST with downward, with followed by T wave inversion with incomplete right bundle. If black athlete, you can pass it, but here the complete T wave inversion in all chest leads, this is myocarditis. At last, there are gaps in evidence outcome in exercising individuals with cardiovascular disease. The natural history and absolute risk of conditions associated with sudden cardiac death in athletes identified through cardiovascular screening is largely unknown. You can find some abnormalities and it can be not pathological, but in other cases can be pathological, so it needs full investigation. This is the summary of the ECG abnormalities that can be passed as acceptable or pathological. Thank you for listening. And these are some references. Thank you.